today's topic is, so do you guys know anything about behavioral disorders? So we are going to deal with behavioral disorders in pediatric age group. So, whenever somebody comes to the OPD, sometimes parents come with a complaint of their child being very stubborn, not listening to them. सुनाई दे रहा है? Am I audible? तो मैं तो लेक्चर अटेंड नहीं करना है ना? अरे शक्ल पे लिखा हुआ है. The child being very aggressive. Sometimes the school teacher or school principal might complain about the child's behavior. So these are kind of examples which point towards behavioral problems in children. तुम लोग कहोगे हमें भी है वो तो. So it is important to identify these problems in the initial stages as they can be managed optimally. The sooner you identify, the better, and the earlier you can treat those problems, right? So behavioral problems in children are reported by parents and school teachers in the developmental period. So Ajo, don't distract me, just keep on coming, okay? And write down your attendance here in this sheet and sit. पीछे नहीं जाना, आगे बैठना. So these children are all also termed as maladjusted or having emotional disturbances. These problems are related to inappropriate behavior and feelings. So these problems are related to the inappropriate behavior, their feelings, unsatisfactory interpersonal relationships, school learning problems, the child being not happy, physical symptoms, and fears related to school, like how your fears coming to college. Do you have? I don't know. So they are very common in children, and so out of that, serious disorders are like 10 to 15%, and they are seen in both genders. But some of them, like ADHD, is more common in males. Changing socio-cultural scenario is one of the most important factors for increase in this kind of behavioral problems in children. So, what is the criteria to label a child as having a behavioral problem? First of all is the age. Then is the frequency, how often it is. How severe is the behavioral disorder, and what impact it has on development. So age. Like for example, some problems, like thumb sucking and anuresis it's not a behavioral disorder in a 2-year-old. But if the same thing a 10-year-old does, it definitely is, right? And frequency, if it happens like once or twice, it is okay. But if it happens repeatedly, then definitely it is a problem. Severity. Kitna severity that problem is, like, it is causing maladjustment in that child. And effect on development is like, suppose the child complains of, abdominal pain early in the morning. Once or twice it is okay. But every day if the child has that kind of problem, for that he wants to avoid school. And then what will happen? Academic performance will decline if the child will not go to school, right? So these are the criteria wherein you label for the child to have a problem. So common behavioral problems. The first one is a habit disorder. What is a habit disorder? What do you mean by habit? Habit. Adat. What do you mean by that? Habit disorder is term used to describe several related disorders linked by the presence of repetitive and relatively stable behaviors that seem to occur beyond awareness of the person performing it. The child does not know that I'm doing this, right? Somewhere in his conscious, he is not able to judge that whatever he is doing is wrong. Some common habit disorders like tics, temper tantrums, thumb sucking, nail biting, breath holding spells, teeth grinding, and bruxism. I've not covered all of them. I've just covered the important behavioral disorders, okay? So breath, let's go to the first one. What is a breath holding spell? What do you mean by breath holding spell? Have you heard before about breath holding spells? Yes or no? हाँ तो ना तो बोला, नहीं बोला, नहीं है तो कोई बात नहीं, मैं थोड़ा ना डंडा मारूंगी कि नहीं, क्यों नहीं देखा और क्यों नहीं सुना. सुना है? What are breath holding spells? No? Okay. So they are reflexive events typically initiated by provocation. What do you mean by provocation? If you provoke the child, that the child wants something else, he is demanding something from the parents, and if the parents do not fulfill the desire, the child cries at full expiration, then he becomes apneic and cyanotic spells, and he may lose consciousness, and he may become hypertonic and fall. So how do you differentiate that, whether this child is having a breath holding spell or whether he's having a seizure activity? How do you differentiate between this? Because some of these children, if they are in a, if they have breath holding spell for a longer time, they can go into seizure activity. Ajo. Breath holding spell always revert on their own. They last for very, few seconds and the child resumes normal activity. Or sometimes what happens after that full crying episode, he might just go to sleep or he might, you know, have a normal activity after that. So these spells are rare before 6 months क्योंकि 6 महीने से कम वाले तो करेगा ही नहीं उसको आता ही नहीं है. They peak at around 2 years and they abate by or they subside by 5 years of age. So how do you diagnose that this child has a breath holding spell? The parent or the mother or the caregiver will give you a typical history that बच्चा बहुत ज़्यादा जिद करता है, आप इसकी जिद पूरी नहीं करो तो जोर जोर से रोता है और बेहोश हो जाता है, नीला पड़ जाता है, बेहोश हो जाता है. That's how they will come and tell you. So you will think whether it's a seizure or whether it's a breath holding spell. How do you differentiate between both of this? So based on the setting, the parents will give you a typical history, typical sequence of crying, cyanosis, or pallor without brief loss of consciousness. What are the differential diagnoses? If a parent is coming and complaining to you that this is the history, they give you a particular kind of history, and then how do you differentiate? Okay, what exactly is the child having? It can be a seizure activity, it can be any kind of arrhythmia, it can be a brainstem malformation. So the difference, how we differentiate between them is like, first of all, is a typical history of provoking event, stereotype pattern of events, and color change preceding the loss of consciousness, helping in distinguishing breath holding spell from seizure, right? एक टिपिकल हिस्ट्री होगी. सीजर में कभी भी बच्चा पेरेंट ऐसे हिस्ट्री नहीं देगा कि बच्चा जिद कर रहा है, उसकी जिद पूरी नहीं करो तो रोएगा और फिर बेहोश हो जाएगा. सीजर तो कभी भी कहीं भी आ जाएगा. दे विल नॉट हैव अ प्रोवोकेटिंग इवेंट. सो एंड ब्रेथ होल्डिंग हैज अ प्रोवोकेटिंग इवेंट. The second way to differentiate this is by EEG, by electroencephalogram. How do you do that? So your EEG will be abnormal in case of a seizure, but it will be absolutely normal in a breath holding spell. How do you differentiate this thing? If rule out cardiac malformation, in case spells are with pallor, then ECG is done to rule out cardiac arrhythmia and long QT syndrome. How do you manage this kind of behavior? Why don't you come here? Why are you sitting right in the corner? Are you able to see what is there? Or you don't want to? So after a long and thorough examination of the child, parents should be reassured that this is absolutely a normal thing. Okay? क्योंकि कई बार पेरेंट्स आते हैं बहुत घबराए हुए कि हमारा बच्चा बार बार बेहोश होता है, रोता है और फिर बेहोश हो जाता है. So definitely it is a concern in any parent, right? So they should be explained that apneic spells are always self-limited and do not lead to any kind of brain injury or death in a child. And the family's behavior should be consistent and they should remain calm during that event. आप हाइपर हो जाओगे खुद भी फिर वही गिर जाएंगे बेहोश होकर. ठीक है. चाइल्ड शुड बी टर्न टू द साइड एंड ताकि सीक्रेंस जो भी आ रहे बेहोश हो रहा है बच्चा ताकि वो एस्पिरेट ना कर ले तो उसके नेक को साइड में कर दो. If you can, like, sometimes it is difficult because what happens, like, parents keep on coming to the OPD with this similar kind of history. At times it is difficult with the history also to differentiate whether it was actually a seizure or a breath holding spell. So we always ask the parent to record the event so that it is helpful for us to see as to what exactly the child is having. Parents should avoid exhibiting undue concern nor give in the demand of the child if spell is provoked by anger or frustration. Also, some children with iron deficiency anemia can manifest like this. They can have breath holding spells. The second one is temper tantrums. So what is a temper tantrum? It includes behavior that occurs when the child responds to physical or emotional challenges by drawing attention to himself, like yelling, biting, crying, kicking, pushing, or throwing objects. Okay. So typically it begins at around like 18 to 36 months of age. And why does it occur? Why does the child has this kind of manifestation? Because they have inability to assert autonomy. complex task on his own. So if he or she is not able to do, it causes frustration in the child, right? Which cannot be communicated. They can't tell you because they have limited verbal skills. छोटे बच्चे आपको बता नहीं पाएंगे वो क्या फील कर रहे हैं, तो इसीलिए दे manifest in the form of temper tantrums. Why they have limited verbal skills? Because every development has its particular age, right? So the frustration therefore is acted out as undesired behaviors. Okay, so this behavior peaks at around 2 to 3 years of age, and they subside by 3 to 6 as child learns to control his negativism. Now, parents to be asked to list how do we manage this. So we always ask the parents के क्या क्या चीजें बच्चे करता है, तो वो उनका आप एक लिस्ट बनाओ where disruptive behavior is likely to occur. What happened? Are you concerned about something? No? So during tantrum, parents' behavior should be calm. Again, the same thing. They should be consistent. Should not permit the child to take undue advantage of the situation. The child should be protected from injuring self and others. At an early stage, distracting the attention from immediate cause and changing the environment. जब पेरेंट को पता चल गया है कि ये चीज हम इसके लिए नहीं करेंगे तो ये टेम्पर टेंट्रम थ्रो करेगा, ठीक है, तो उसको अवॉइड कर दो. चेंज दैट सिचुएशन, टेक दैट चाइल्ड अवे फ्रॉम दैट पर्टिकुलर सिचुएशन. आप उसको होने ही मत दो, शुरुआत ही मत करने दो उस चीज से. So at an early stage, you distract the attention from immediate cause and change the environment, okay, to abort the tantrum. Now next one is a tic disorder. Are you getting what I'm teaching? Are you getting? Are you able to understand? तो एकदम शांत, एकदम blank look के साथ बैठे हुए सब लोग. So the next one is a tic disorder. So what are tics? They are characterized by involuntary, rapid, repetitive, single or multiple. They can be motor, they can be vocal, or they can be phonic tics that wax and wane in frequency but have persisted for more than a year. You know, parents will give a typical history of like कई महीनों से चला आ रहा है. If it is less than a year, we keep the diagnosis as provisional. What are the types of tics? They can be again divided into motor and vocal. Motor again further divided into simple and complex. Again vocal is again further divided into simple and complex. So the motor tics are simple motor and complex. Okay. So simple में क्या होएगा? They usually involve one single group of muscle like eye blinking, head jerking, nose twitching, shoulder shrugs, arm jerks and mouth opening. And the complex one, they involve either a cluster of simple actions or more coordinated sequence of movements. Example movements that can be non-purposeful such as facial and body contortions or twirling around, okay? Like hopping, touching, hitting, jumping, all this kind of. The child will repeatedly do this. Now let's come to vocal tics. So again, simple vocal tics, it includes various sounds and noises without meaning like grunts, barks, hoots, sniffs, screeches, moans and throat clearing. And the complex one again is vocalization that involves repetition of words or sentences or phrases. So this is again further divided into 3 types. Okay, obscene, like the child uses abusive language, that is known as coprolalia. Repeating one's own words, that is palilalia, and repeating the last word that they heard. Today is Sunday, 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 to वो करते जाएंगे. Okay, it is echolalia. Individual tics can suppress from varying periods of time. How can we suppress this? So what happens is, you know, when you given the external demands, exert the influence, and when you deeply engage in a focused task or activity or during sleep, they are often worsened by anxiety, excitement and exhaustion. So this is just for your information that in a subset of children, there are a lot of slides which are not for your this thing. So I'll be skipping those, okay. So tics are caused by preceding group A beta streptococcal infections in labeled as pandas, pediatric autoimmune neuropsychiatric disorders associated with streptococcal infection. Also, we have a lot of comorbidities which are associated with tic disorders. One is ADHD, obsessive compulsive disorder, depression and anxiety impulse, and control disorders. So, how do you assess a tic disorder? Just know the names because it's not important for you. The Yale Global Tic Severity Scale, because this is too much into detail, not for you, okay? You should know that there are some scales which are used to assess the tic disorders. So, the Yale Global Tic Severity Scale and the GTS scale, okay? And how do you treat a tic disorder? First of all is the general one. What advice do you give? Individual with tic disorder should have the careful assessment of tics and comorbid condition. अगर उनको comorbid condition, as I told you in the previous slide, if they have that, then determination of the problem severity and impairment, you know, and how severe is that? कितने बार बच्चा कर रहा है, कितना often कर रहा है, पूरे दिन करा जा रहा है. Evaluation of general health, family history or prior therapies if the child received any kind of therapy before in the past. Non-pharmacological treatment is again relaxation therapies and habit reversal and comprehensive behavioral intervention for tics. So in relaxation, what do? Progressive muscle relaxation. जो muscle group of muscle या single muscle जो भी involve हो रही है उसको उसकी relaxation technique बताओ आप. Deep breathing exercises बताओ. Visual imagery and autogenic training, that is repetition of statements suggesting a relaxed state. Pharmacological treatment, usually we don't come to pharmacological treatment unless it's very disturbing. So when do you consider pharmacological treatments in tic disorder? Only in if it is causing severe impairment in the quality of life and also other medication responsive comorbidities are present. बाकी दूसरी कोमॉर्बिडिटी भी है जो मेडिकेशन उसके लिए काम करेगी तो हम उस टाइम पे प्रिस्क्राइब करते हैं. लाइक FDA approved dopamine receptor blocking medications like haloperidol and pimoside are effective, but their side effects, they have lot of extrapyramidal side effects, जिसकी वजह से they are not the first line of treatment. Atypical antipsychotics like risperidone and alpha-2 adrenergic agonists like clonidine and guanfacine. Head banging, head rolling or body rocking. I think everybody knows what it is, right? So may occur separately or together in otherwise healthy children around sleep time. What do you do if the parent comes? Reassure that it rarely results in any kind of injury and will usually remit by 4 years of age without any intervention. You don't need to give in any intervention to abort that kind of banging. Parents should remain calm and not give attention to the... See, for all the behavioral disorders, the same kind of assurance applies, right? एक दो चीजें different होगी, बाकी तो overall same ही है. And if the behavior it is persisting beyond 4 years, then you need to evaluate further. This is the child doing head banging. Nail biting. Everybody knows what is nail biting. I think we all do it, right? At this age also. It's again oral habit, especially in school children beyond 4 years of age, caused by feeling of insecurity, conflict and hostility. It may be due to pressurized study at school or home. How do you manage? Of course, what everybody does, cut down the nails, ताकि उसको class में नहीं काटने पड़े बैठ के ना. Then increase awareness of habit, like have them look in the mirror while biting their nails. Teach a competitive response. उसका कुछ और उसको सिखाओ, like chewing gum or blow air through the pursed lips ताकि वो करे ही नहीं. Relaxation techniques. Thumb sucking, again normal in infancy and toddlers, whereas abnormal in preschool and above 5 years of age. Now complications is malocclusion. What will happen if the child repeatedly does? I think we all have done somewhere in when we were toddlers, right? So what happens? Malocclusion and malalignment of teeth, difficulty in mastication and swallowing, deformity of thumb. क्योंकि अगर पूरे दिन बच्चा अपने thumb को मुंह में रखेगा तो definitely facial distortion, speech difficulties with consonants like D and T, and thumb sucking कर रहा है, सारे surfaces को touch कर रहा है, definitely he is going to have GIT infections. How do you manage this? Distraction during the board time or engaging the thumb or finger into some other activity. Child should not be scolded for that particular habit. Consultation with the dentist or a speech therapist, and of course hygiene measures. Like, what are oppositional defiant disorder and conduct disorders? This is again the second category. What are they? They are characterized by a core deficit in self-regulation of anger. गुस्सा सब करते हैं, बट गुस्सा कितना ऑफ्टन हो रहा है, कितने डेप्थ में हो रहा है, कितनी बार हो रहा है, वो ज्यादा जरूरी है. ओके, इन सेल्फ रेगुलेशन ऑफ एंगर, aggression, defiance, and antisocial behaviors. So, oppositional defiant disorders (ODD) is characterized by pattern, which is this kind of behavior lasting for at least 6 months of angry, irritable, argumentative, and defiant behavior exhibited during interaction with at least one individual who is not a sibling. Sibling के साथ तो सभी करते हैं, और उसके अलावा भी अगर बच्चा बाहर जाके करा then definitely it is abnormal. करते होगा ना? For preschool children, the behavior must occur on most days, whereas in school-age children, the behavior must occur at least once a week. The severity of the disorder is considered to be mild if the symptoms are confined to only one setting. या तो घर पे कर रहा है बच्चा, स्कूल में कर रहा है, या खेलने जा रहा है तब कर रहा है, या काम पे तो क्या, एट वर्क जो भी होगा वो. Moderate if they are present in 2 settings, and severe if they are present in 3 or more settings. So, conduct disorder. After ODD is the conduct. ODD leads to conduct disorders. It's characterized by repetitive and persistent pattern over at least 12 months of serious rule-violating behavior, in which the basic rights of others and major societal norms or rules are violated. कुछ बड़े लोग भी करते हैं ये, शायद तोड़ा फोड़ी, है ना? The symptoms of conduct disorder are divided into 4 major categories, like aggression to people and animals, destruction of property, deceitfulness or theft, and serious rule violations. So, what is the clinical course of ODD and CD? ODD behavior can occur in all children and adolescents from time to time, particularly during toddler and early teenage periods when autonomy and independence are normative development tasks. So, oppositional behavior becomes a concern when it is intense, when it is persistent and pervasive, and when it affects child social, family, and academic life. Some of the earliest manifestations of oppositionality are stubbornness. They start showing some kind of behavior at an early age, being very stubborn, defiance and temper tantrums. जो पहले भी जितने भी हमने पढ़े हैं, they can lead to this kind of ODD in future. Argumentativeness. Approximately 65% of children with ODD exit from the diagnosis. अगर हम उनको जल्दी आइडेंटिफाई कर लेते हैं और फॉलो अप पे रेगुलरली बुलाते हो, तो 3 years, at around like 3 to 4 years, they exit this kind of diagnosis. They no longer have this. Okay. ODD often precedes the development of CD, as I told you before. Onset of conduct disorder may occur as early as the preschool years, but the first significant symptoms usually emerge during the period from middle school through middle school adolescence. Onset is rare after 16 years. What is middle school? Yeah. In majority of individuals, the disorder remits by adulthood. In a substantial fraction, antisocial personality disorder develops. ठीक है? ODD and CD further leads to antisocial personality. Individuals with CD also are at risk for the later development of mood, anxiety, post-traumatic stress, impulse control, psychotic, somatic, and substance-related disorders. So let's look at the comorbidities. Rate of ODD are much higher in children with ADHD, which suggests shared temperamental risk factors. ADHD and ODD are both common in individuals with conduct disorders, and this comorbid presentation predicts worse outcome. Now, conduct disorder may also occur with anxiety, depressive, bipolar learning, language, and substance related disorders. How do you manage this kind of behavior? Treatment of both ODD and CD has to be dealt with together as for all practical purposes. Both the disorders seem to be a part of a continuum. One leads to other. Now, another factor to be taken into consideration is the presence of ADHD, that is the comorbid conditions if they are there, learning disorder, depression, anxiety, substance abuse for making management complicated. Interventions included. What are the interventions that we need to follow in this kind of disorder? First of all, definitely is the prevention. Then is the pharmacological treatment, non-pharmacological counseling, and school-based interventions. Prevention, everybody knows what you have to do, right? Psychopharmacological treatment. It can be tried in few cases. It shows good result when associated with ADHD. Methylphenidate, ADHD is the drug of choice and helps in most cases. Risperidone is used to improve aggressive behaviors, and Sibilance stays as the first choice for use in ODD and PD, and anticonvulsants is the second group of medication for non-specific aggression. Lithium can also be used. So, what are the non-pharmacological interventions that are there? So, individual counseling for adolescents and young adults to enhance coping skills, anger management, stress management, assertiveness training, and social skills. I think everybody knows what is Pica. Do you know? You must have definitely heard before, right? आपकी पोस्टिंग हुई है पीडियाट्रिक में तो सुना ही होगा ना? हाँ या ना? तो बोलो. So what is Pica? What is Pica? Can anybody tell me what is Pica? Involves persistent eating of non-nutritive, non-food substances like paper, soap, plaster, paint, etc. over a period of at least 1 month. The eating behavior is inappropriate to the developmental level. Example, the normal mouthing and tasting of object in infants, that is definitely normal, but if it occurs at a later age group, it is definitely abnormal. A minimum age of 2 years is suggested. So, the eating behavior is not a part of culturally supported or socially normative practice. Pica can occur throughout lifetime, but occurs most commonly in childhood. It appears to be more common in those with intellectual disability and autism spectrum disorders, and to a lesser in obsessive compulsive and schizophrenic disorders. It appears to increase with severity. इसकी ज़्यादा intellectual disability अपना ज़्यादा होगा. It usually remits in childhood but can continue into adolescence and adulthood. So, कहाँ चला गया? Children with pica are at increased risk of lead poisoning, iron deficiency, anemia, mechanical bowel problems, intestinal obstruction, intestinal perforations, dental injury, and parasitic infestations. It can be fatal on substance, depends what the child is taking, right? Now, etiology. Child might have nutritional deficiency like iron, zinc, and calcium. कुछ लोग सुना ही होगा, पेंट हटा के खाते हैं, दीवार कुरेद कुरेद के खाते हैं. लो सोशो इकोनॉमिक स्टेटस, चाइल्ड अब्यूज, बच्चा नेग्लेक्टेड है, कोई ध्यान नहीं दे रहा, कुछ भी करे जा रहा है बच्चा. फैमिली डिसऑर्गेनाइजेशन लाइक पुअर सुपरविजन फ्रॉम द पेरेंट्स, some kind of mental disorder in the child, learned behavior, and cultural and familial factors. Assessment of neglect and family supervision combined with the psychiatric assessment of co-occurring mental disorders and developmental delay are important in developing an effective intervention strategy. The sequelae related to an ingested item can require specific treatment, like है तो let टॉक्सिसिटी है तो उसका ट्रीटमेंट करो, आयरन डेफिशिएंसी है तो आयरन सप्लीमेंट्स दो, पैरासाइटिक इन्फेस्टेशन है तो ट्रीट दैट. इंजेक्शन ऑफ हेयर कैन रिक्वायर मेडिकल और सर्जिकल इंटरवेंशन. गैस्ट्रिक बिजॉर्डर पढ़ा होगा तुम लोगों ने. व्हाट इज एन्यूरेसिस? या नहीं पढ़ना? हाँ, मुझे पता बोरिंग है, मुझे भी बोरिंग लग रहा है. Anuresis is the repetitive involuntary passage of urine at inappropriate place and time. Because पर बोरिंग तो है, लेकिन यही बच्चा जब आएगा तब कैसे ट्रीट करोगे, बताना तो पड़ेगा ना. क्यों हंस रहे हो तुम लोग वहां पे बैठ के? Repetitive involuntary passage of urine at inappropriate place and time. Imagine how boring it must be for me to make all these slides. In a child above 5 years or more, it is found in 3 to 10% school children. This is important anuresis. So in our nephrology department, we have lots of kids with this kind of problem, right? अभी मजाक लग रहा है, लेकिन जब बच्चा होता है, प्रॉब्लम जब फेस करते हैं पेरेंट्स, तब it is actually disturbing. Emotional factors. Hostile or dependent parent child relationship. Dominant है बहुत ज़्यादा पेरेंट, हर छोटी छोटी चीज़ के लिए पनिश कर रहे हैं. Sibling rivalry. Emotional deprivation due to insecurity and parental death. You know, if no parent is there or if there's a death of one parent, it is psychological stressing for the child. Environmental factors. बच्चे को टॉयलेट तो आ रही है, लेकिन वो जाए कैसे? ठीक है, डर के मारे, अंधेरे के मारे जाता नहीं है. टॉयलेट एट अ डिस्टेंस फ्रॉम बेडरूम में कॉज बेड वेटिंग. जा रहा है लेकिन रास्ते में ही निकल गया क्योंकि टॉयलेट बहुत दूर है. वी आर लकी इनफ टू हैव टॉयलेट्स इन आवर हाउस, राइट? बट एवरीबडी इज नॉट, राइट? द एसोसिएट ऑर्गेनिक कॉज में प्रेजेंट, लाइक स्पाइना बाइफिडा है तो न्यूरोजेनिक ब्लैडर. You have to do X-ray of the LS spine and rule out whether the child has any kind of neurological disorder. Juvenile diabetes mellitus, or it may be a seizure disorder. क्यों? क्योंकि at the end of seizure, child passes urine. Bladder bowel incontinence होती है at the end of seizure. Management. How do you manage this kind of anuresis? And first is the urotherapy. Non-organic causes to be managed primarily with emotional support to the child and parents along with environmental modification. Restriction of fluid after dinner, voiding before bedtime, and arising the child to void once or twice 3 to 4 hours later, right? Alarm therapy, electronic device which sends moisture and trigger an alarm. Drug therapy, बहुत सारी है, मिप्रामेन और वो सब है, बट पहले तो यही सब यूरोथेरेपी ही काम ट्रायल देते हैं, उसके बाद में हम ड्रग थेरेपी देते हैं. बिकॉज ड्रग थेरेपी भी कोई इतनी ज़्यादा इफेक्टिव होती नहीं है एन्यूरेसिस में. सो दिस इज द अलार्म थेरेपी. होगा फिर पजामा के ऊपर एक कॉर्ड रहती है और अंडर जो सेंसर होता है वो अंडर पैंट्स में आप उसको अटैच कर देते हो. जैसे ही वो गीला होएगा अलार्म बजेगा. Substance abuse, everybody knows what is substance abuse, right? I don't think so I need to teach this. सबको पता है, सभी करते होंगे. Let's come to attention deficit hyperactivity disorder. So DSM-5 defines ADHD as persistent pattern of inattention and or hyperactivity, impulsivity that is more frequently displayed and more severe than is typically observed in individuals at a comparable age. कुछ हद तक सारे बच्चे करते हैं, but you need to compare with the overall pediatric population के. और ये जहाँ पे बच्चा जा रहा है स्कूल में या खेलने जा रहा है, उसका कोई peer group है, वहाँ पे उनसे ज़्यादा बच्चा अगर एक्सेसिवली कर रहा है, समटाइम्स इट्स वेरी डिफिकल्ट टू डायग्नोज ADHD. तो उनके मात्रा में वो बच्चा कितना ज़्यादा कर रहा है. मोस्ट कॉमन न्यूरो बिहेवियरल डिसऑर्डर इन चिल्ड्रन, ADHD इज द मोस्ट कॉमन वन. ओके, Signs and symptoms of ADHD typically appear before the age of 7 and should be present for at least 6 months and pervasive. That is present in two different settings and impair the child's ability to function normally. So we have three kind of ADHD. Predominantly hyperactive impulsive. मोर इसमें क्या होगा अगर बच्चा हाइपर एक्टिव इम्पल्सिव टाइप का होगा तो 6 or more symptoms are in hyperactivity and impulsive. तो हर किसी के ग्रुप्स हैं तीनों के हाइपर एक्टिविटी इम्पल्सिव एंड इनअटेंटिव तीनों के ग्रुप्स हैं तो उसमें बहुत सारे क्राइटेरियाज हैं लाइक 8 to 10 और उसमें से अगर 6 से ज़्यादा है इन द हाइपर एक्टिव ग्रुप देन इट इज एंड लेस देन 6 symptoms of inattention यानी जो टाइप है उससे ज़्यादा होनी चाहिए और दूसरे के कम है समझ रहे आप लोग Did you get what I'm trying to tell you? Then it is predominantly hyperactive impulsive type. The second one is inattentive. The majority of the symptoms, like 6 or more, 6 is the criteria, or more in inattention category. 3 categories दी हैं इन सबकी, and less than 6 in the hyperactivity. Impulsive may still be present. The third one is the combined hyperactive, impulsive, and inattentive. So these children have more than 6 symptoms each of inattention and hyperactivity, impulsivity. This is the most common one. The combined type of ADHD is the most common type of ADHD. So these are like the diagnostic criteria. ये पूरा नेल्सन का टेबल है इसमें सारे दिए हुए हैं पॉइंट्स और इनमें से कोई भी 6 या 6 से ज़्यादा जो भी हम टाइप पे कैटेगराइज कर रहे हैं उसका ठीक है यू डोंट नीड टू नो दिस वैसे भी अगर तुम्हें पीडियाट्रिक्स लेनी होगी तो वैसे ही पढ़ लोगे दिस ऑल्सो इज टू मच इन टू डिटेल फॉर यू वांट सो लेट मी टेल यू सम ऑफ द डिफरेंशियल डायग्नोसिस ऑफ इनअटेंशन hyperactivity disorders. What are the diagnosis? What are the psychosocial factors? Response to physical or sexual abuse, then response to inappropriate parenting practices. बच्चा क्यों करेगा कहीं ना कहीं तो उसको दिखाना है ना अपना भी फ्रस्ट्रेशन ठीक है बोल तो पाता नहीं हूँ समझ इतना पाता नहीं है Response to parental psychopathology. Parents might also exhibit that kind of behavior. Response to acculturation. Then response to inappropriate classroom setting. Diagnoses which are associated with ADHD behaviors. Fragile X, fetal alcohol syndrome, pervasive developmental disorder, OCDs, falana falana. Medical and neurological conditions, thyroid disorders, heavy metal poisoning, then adverse effects of any medication if the child was on certain medication, then effect of abuse substances, सेंसरी डेफिसिट है कहीं बच्चा सुन नहीं पा रहा है देख नहीं पा रहा तो इसकी वजह से ऐसे कर रहा है ऑडिटरी एंड विजुअल प्रोसेसिंग डिसऑर्डर देख तो पा रहा है लेकिन उसको प्रोसेस नहीं कर पा रहा है इस इंफॉर्मेशन को इसीलिए ऐसे हाइपर एक्टिव बिहेव कर रहा है न्यूरो डिजेनरेटिव डिसऑर्डर्स स्पेशली ल्यूकोडिस्ट्रोफिस दिस इज टू मच फॉर यू पोस्ट ट्रॉमेटिक हेड इंजरी और पोस्ट एनकेफेलाइटिक डिसऑर्डर Familial pattern, it has been found that it is more common in first degree biological relatives of children with ADHD than in general population. That's all. So there are more that are there like encoparesis or वो सब चीजें हैं which I have not mentioned into my slides because these are the most important ones that you need to know.